with that, let me just put the PowerPoint up on the screen so we can all see the presentation. And then we'll go ahead and get started. So with that, Dr. Moore, sorry, take it away.
It's okay. Hi, I am Dr. Makita Moore, and I'm a pediatrician with Advocate Medical Group. I am working with the Illinois chapter of American Academy of Pediatrics on their primary care primer on housing insecurity in children, first steps improving child health and housing. So the goal of the First Steps project is to promote and to advocate for increased housing capacity and systems of care to prevent and abate child health risks that's associated with housing instability, with our primary focus on 0 to 6-year-olds and pregnant women. And so with our current unemployment rates increasing, there is a higher risk of housing insecurity. Therefore, this project is very vital. And we are so thankful that you are joining us. So we are also grateful for our list of contributors and partners that are shown here. So for the goal of this webinar is to become familiar with definitions and scope of homelessness and housing insecurity, and to learn how to sensitively address housing insecurity in patients, to develop understanding of clinical guidelines with the housing insecure population, and to become familiar with screening tools and referrals for children and families that are experiencing housing insecurity. So we are going to cover these goals through 5 sections. First being overview of Chicago housing system. Second being the practice site and physician cultural sensitivity. Third is the patient communication and identification of risk. Fourth is the clinical guidelines. And lastly is the referral options and tools. So for the first section, we're going to have John and Lo with the overview of the Chicago housing system.
Hi, good morning, everybody. Greetings. Once again, my name is John Lo. I am a senior program manager at CSH, or Corporation for Supportive Housing. I'm happy to be here with you all today and hope to provide some new information to you all about the housing and homeless systems in Chicago. The housing and homeless system is a huge entity in Chicago, and unfortunately, we won't have enough time to cover all the details about these systems. We do hope to provide some understanding on various terms, a brief history, and the interconnectedness and the relationship of these systems here in Chicago. Oops, sorry, wrong way. We hope to provide clarity of specific terms and how not all entities have the same definitions, a glimpse into the needs and scope in our city, how not all communities are affected the same by these issues of homelessness, and later get into the resources. We're going to now move into some of those definitions. In the housing and homeless sector, sometimes terms are very similar, the same, but have different criteria or can mean different things to different groups. We have heard terms like housing insecurity, unstable housing, literal or street homelessness, doubled up, and couch surfing. 2 things to take into consideration. If a person is enlisted on a particular lease, they could be experiencing or at risk of experiencing housing insecurity. The other thing that we want to take out of our speech is judgment and prejudice. Moving away from calling people homeless, a particular period of time, especially a very vulnerable time, shouldn't define us. Try to utilize person-first speech. Move away from phrases like the homeless family or the homeless man, and try to replace it with terms like people experiencing homelessness or people experiencing housing instability. So this slide shows us the United States Department of Housing and Urban Development, or most people know as HUD's homeless definitions. So we see number one is the literal homeless definition. Number two is the immediate risk. Number three are other considerations that really talk about youth and families with children. And then number four is that domestic violence. So HUD's Homeless Emergency Assistance and Rapid Transition to Housing Act, or also called HERTH, of 2009. The HERTH Act streamlines HUD's homeless grant programs by consolidating the supportive housing, shelter plus care, and single room occupancy grant programs into one grant program through the community, in our case, Chicago's Continuum of Care program. The HERTH Act, created in 2009, was formerly known as the McKinney-Vento, streamlines HUD's homeless grant programs by consolidating them into one, as I mentioned. Children and youth experiencing homelessness have a different definition than the adults. Entities like schools and service providers that focus on children look at things through a different lens. The McKinney-Vento Act is a federal law that ensures the right of students to go to school even if they are experiencing homelessness. We would love to believe that everyone who needs support will get it in a timely fashion. The reality is that funding and supports for people in need don't always match up to the need in many communities, especially a big complex city like Chicago. In Illinois, 8 out of 10,000 people are experiencing homelessness. And in Chicago, 21.8 people out of 10,000 are experiencing homelessness. This data comes from the Chicago's Point in Time report conducted every year. Every year, communities conduct a point in time count to collect data on sheltered and unsheltered people experiencing homelessness on a single night in January. The report for Chicago is produced by the Department of Family and Support Services and also by UIC's Voorhees Center of Neighborhood and Community Improvement. We can provide details of the links at the end of the presentation or at a later point. But the count is done to provide a clear understanding of the state of the issue in our state and also in our city. HUD defines sheltered people as adults, children, and unoccupied children who on the night of the count are living in shelters. This includes all beds dedicated for use by homeless persons that are reported to the Continuum of Care in their housing inventory count, also known as HIC. Included dedicated beds located in emergency shelters, domestic violence shelters, any hotel, motel, or apartment voucher arrangement paid by a public or private agency because a person or family is experiencing homelessness. Safe havens, transitional housing, including HUD-funded rapid rehousing demonstration grant programs. Despite making up about 1/3 of the city's total population, the Black or African American representation remains high at 69.1% of sheltered and 73.5% of unsheltered population. The white population comprises 25.4% of the sheltered population and 22.5% of the unsheltered population. The percentage of unsheltered African American decreased slightly as it did with the unsheltered white population. This slide shows experiences of homelessness by age. Whether it's experiencing literal homelessness, at risk, or doubled up, children are impacted by homelessness. This data comes from Ending Child Homelessness Report from Urban Labs. These two sources do not comprehensively capture all families experiencing homelessness in Chicago. For example, families living doubled up that have children who are not school age or not enrolled in a Chicago public school will not be captured in this estimate. This study estimated at about 10,000 Chicago families experienced homelessness last year, or what is considered 2018, I guess. But only 1,300 accessed those continuum of care services, indicated many more families and children have housing needs, and many are not accessing those housing and services through our Chicago's homeless service system. This report too comes from Urban Lab and was created in 2018. The realities of the housing and homeless sectors have realities that were not created overnight. The next few slides will highlight some of the issues historically in the nation and in Chicago. In order to understand the current American dynamics of the homeless sector, we must factor in the historical context. These particular events have built upon each other historically, and they have ultimately left people of color disadvantaged and without sustainable resources. Institutionalized racism created policies to ensure people of color were not able to accumulate wealth and have the same access to resources as white people. All these structures created a very convoluted and distressing reality for people of color, comprising a disproportionate rate of homelessness. Chicago's segregation is rooted in formal housing policies like redlining, and these implicit and blatant discrimination and prejudice reinforced by both the public and private sectors show Chicago's residents live very separately. We will now move into discussion about the interventions and resources available within the homeless sector. There are resources for families who are experiencing homelessness. Definition of these interventions and how to ensure your patients get connected will be covered in the final section of this training called Referral Options and Tools. We're now going to transition into talking about physician and practice site cultural sensitivities led by Dr. Marquita Moore.
Hi guys. So for this section, our goals is to identify steps needed to have an inviting practice site and to apply physician and provider cultural sensitivity for the housing insecure population. So we're going to figure out, why is this needed? Well, basically, if you can have an inviting and non-judgmental atmosphere, that can foster trust. And then trust can open communication, and that can lead to ideal health outcomes. So we're going to talk about staffing, scheduling, and physician care. So the first thing is staffing. So with staffing, diversity and inclusion is very important, because if they can see somebody that looks like them, that can sometimes ease tension. And also translation is also important, because you want the parent to maintain control. So we shouldn't let the child interpret or a friend do it, because then that parent might not feel empowered. And we should also have ongoing competency training, because we also want to stay current and be held accountable. In doing this ongoing training, it would be very important if we got feedback from the population that we are serving, so that we can know if what we're doing, if it's working. And we also need to adapt services and an atmosphere too, because if we can have a patient navigator help this family try to go from specialists or from routine care visits, that will be helpful. Because being in the medical world, we are familiar with it, but for patients, it can be very intimidating. And it's also helpful if we can have information out that's about transportation services, prescription services, job opportunities. We're going to move into scheduling. So it is very important if we give them priority, because scheduling can be unpredictable or just difficult if you have a housing insecure family. Because what if their transportation, if they can only come during, let's say during lunch, then we should be able to help them out with that. And also prior to the pandemic, we might have done walk-in visits, but I'm sure now that that option is kind of not as frequent. Maybe if we could have morning and some evening day slots, that would help them, because the goal is to reduce ER visits and to promote continuity of care. And also, some of the housing insecure families might have more than 2 children and might have a issue with with transportation. So if we can see all of their children like in one day, that would be helpful. So we're going to move to the physician and providers. So we have to treat each visit like it's the last. It should be a comprehensive visit. If we could do labs, if we could schedule imaging for them, if we can help them schedule specialists, that would be very helpful. And that goes back to the patient navigator. Even if we don't have a social worker or if we don't have a caseworker, if we can just appoint somebody that can help families out when they get there, that would be helpful. And also, we would have to ask and screen for social determinants, because we need to know how their housing situation is. And we need to figure out which barriers is in their way as far as to get to appointments. And it's also very important to have effective communication. And in order to have that, we would have to understand that there is a wide range of health literacy. And we cannot make assumptions. And we have to emphasize their strengths and their resilience. And it's also key to maintain empathy and to provide trauma responsive care. And to have empathy, because homelessness is a traumatic experience. And so we should try to see things from their point of view. We also need to recognize that communication may be limited. So if we can get consent from them saying, is there one phone number that if the other ones don't work, that I can leave a medical voicemail or leave a medical message with? And we also need to know that poverty does not mean maltreatment. So we need to know when to report child welfare. It will also be very helpful if we could create a resource sheet, because this will save you time at the end of the visit. If you have information about heating and cooling sites or transportation, that would be very helpful. And then we will also have some items at the end of this section too. And as far as for the medical treatment plan, it would be best if you look at it from their point of view and from their housing situation. Because if we can have if we have to give medication, if it's one that has less doses or that has less days of treatment, that would be very helpful. And also now with the pandemic, I believe that we're all doing a lot of telephone follow-ups, and that could be easier than trying to find transportation. And the AAP also has some recommendations on providing care for our children and for adolescents that are facing homelessness and housing insecurity. So we have to promote Medicaid and become familiar with the chronic illnesses that is in the homeless population. And we have to optimize healthcare visits, have community resources too, and try to get to the root of the cause of the housing insecurity, and also develop shelter-based care. So in summary, cultural sensitivity is the key to providing unbiased care. And we have to have them feel welcome and understood. And we have to just have them know that they matter. And also, this is very important if we have a constant process that requires empathy and concrete policy level action. As far as for implementation and practice, we would need an ongoing competency training. We would need a list of resources. Flexible scheduling is very important. And implementing trauma responsive care, because once again, experiencing housing insecurity is very traumatic. And we need to have a staff member or somebody that can help navigate them with their follow-ups, with getting test results, and some way that like we can track and see if everything helped. If you want more information on trauma responsive care, there's a toolbox on the AAP's, I think it's on their website. If you go there and you search AAP trauma toolbox, this will pop up for you. So in our next section, we are going to have patient communication and identification of risk with Dr. Barbara Belden.
Hi, I think I'm now in control here. This is Barbara Belden, and I'm at Lurie Children's Hospital. And my module is going to be on patient communication and identification of risk, which is going to partially underline some of the concepts that Dr. Moore has just been talking about. I'm not able to, okay, great. And the learning objectives in this module are really aimed at supporting you to address housing insecurity, one of the social influencers of health, and specifically to develop the skills to sensitively and effectively identify these families who have housing insecurity, and then support the medical home-centered communication for those families. We're going to talk about screening in a culturally sensitive way, specific screening methods, communication barriers, as well as follow-up for this population. So how to screen in a culturally sensitive way. And primary care offices, as I know you all know, are one of the major points of contact for families, especially those for young children prior to school. And so as such, the American Academy of Pediatrics has long incorporated surveillance and screening as part of that comprehensive care concept of the medical home. And specifically in the last decade, has created a policy to support social determinant screening, including that of housing insecurity, that can be similar for that of developmental health that we all do and have done for a long time. However, if we hope to do this effectively, we really need to do this in a sensitive manner, since, as Dr. Moore has been saying, these subjects are often very difficult for families to disclose. And while each family is different, there are several common barriers to disclosure that we need to be aware of when we're asking. And asking, are you homeless, can both be ineffective and possibly upsetting to families. So that's because of things like the fact that families may feel shame and fear others will judge them and treat them less well. Parents in specific may be perceived to be guilty or worry that they're going to be perceived to be guilty of neglect, which could trigger DCFS. And again, as Dr. Moore was saying, you can't necessarily know that just because they have a street address, it means that they are not housing insecure, because it could be due to them giving an address of these various places or even a previous residence of theirs. And I want to really underline what Dr. Moore started talking about in about the issue of low health literacy. We know that although all families may have low health literacy, it's much higher risk in this group since poverty is a known risk factor. And the ways we need to address this are having both oral and written communication at a 5th to 6th grade level, emphasizing key points, and having written materials organized so they have bullet points and open space to make it more inviting to read. And particularly using plain language and teach back. And teach back, many of you I'm sure have heard of, is that technique of having patients or parents repeat back in their own words or demonstrate what you've agreed on is necessary to manage health and illness. So an example of that might be asking a parent to tell you the name of the medicine and how much they will give and when, or demonstrating the use of an inhaler. And definitely that's actually recommended to do for all families, especially is important for these. And it's crucial to do this in a way that normalizes it and puts a responsibility on you for any possible lack of understanding. And also realizing these families may wish to have support from either a case manager they bring with them or another staff member of yours. So because our asking can create feelings of prior institutional judgment and families may be worried about consequences of disclosure, it is so important that we ask the right way. Doesn't mean there's only one way to say this, but that it should include specific concepts of how to phrase questions we ask. So it's important to explain why we're asking, that you have a sincere concern, that pediatricians cover all parts of life, even some that may not seem medical because they can all affect child health. Normalizing by say that we ask everyone, and then it's really crucial that we tell them what we are going to do with the information. Remember, they may be worried they're going to be reported for this. So possible ways to say this we put on this slide, starting with, we want to help you be the best parent and have the healthiest family you can. So moving on to thinking about how to actually implement screening for housing insecurity. If you're not currently screening, it will go much more smoothly if you carefully think through the process and make some practical decisions about what the best way is for you to screen in your office, because there is no one best way. You know your setting best and what will work for your flow. So some practical decisions that you would probably want to make is, do you do the screening face-to-face or on paper or both? There is some evidence that people may disclose more when filling out a paper form, but based on some qualitative studies, different people clearly prefer different formats. Who is actually going to ask in your setting? It may work for the medical assistant, the nurse. You can tailor it to your workflow. The most important thing is that whoever does it is trained and feels comfortable asking. And then obviously ensuring confidentiality is key. This could be in the waiting room, or is it better done in an exam room? And then for people who already may be screening, we know they don't all do it the same way and don't do it with the same frequency. We do know that people's situations change, but you need to make a decision about the feasible frequency of your screening. Whoops, sorry about that. Everyone does agree, and this is an important thing to bring up conceptually when you're thinking about screening, is that if it's going to be sensitive and effective, there needs to be a response that has been planned before implementation begins. And we'll discuss resources at length in another section, so I won't discuss it here, but I do want to underline the importance that the level of response may be different in different settings, depending on whether you have in-house resources versus whether you connect to the community. And I do want to mention that empathetic listening can actually be a response in and of itself. Further, each practice, as I said, has different specific resources within the medical home. So it's important to think about how you can include that entire team. No provider can do this on their own. I've already mentioned front desk staff, nurses, or medical assistants. You may be lucky if you have social service support, either a whole program, a single social worker, or even community health workers that go out into the community. But these people have been trained to support families specifically in this area. But the team does not necessarily stop at the door of your practice, and your practice may not have all of that social service support. So you may be identifying the issue and initiating a response, but it's likely that even if you have a social support team, other community organizers will continue with the process. And as I said, that will be discussed further in another setting. And there are specific resources that you can refer to. So for housing resources, depending on whether it's a crisis or if the family is homeless, one of the things you can do is post a coordinated entry system in the waiting room or have it as a handout by the social workers. And then specific groups may have access to particular programs. It's a great idea to have a specific list of resources that you can give to people. In your area, you might want to create a list of community resources such as the Chicago Public School System, legal resources, public aid, child find, and mental health. So what about specific screening methods? And I'm going to go through a few. You're going to have these resources as a specific online resource later on, but just to go through a few of them. One of the obvious decisions that needs to be made is the choice of the screen. There are several validated choices available from an article in Pediatrics in 2018. Sandel and his group picked these two particular questions, and based on whether they were not able to pay mortgage or rent on time, that would be insecurity, versus judging how many different places a child has lived, since if they've moved around a lot, that can be a red flag that they actually are homeless. People have asked about current homeless, so what type of housing does the child live in? Or one could be asking about the history of homelessness. Since the child was born, has she or he ever been homeless or lived in a shelter? Another known resource is one that was created by the Centers for Medicare and Medicaid Services in 2017, talking about what your housing situation is today. And you can see there are a lot of possible answers to this question. I do not have housing, but in that we pointed out a number of different things that could actually not necessarily be interpreted to them as being homeless, but is actually a homeless situation. It's about housing insecurity or saying I actually have housing. The last one on this page is the We Care. Arvind Garg developed this particular question as part of a larger set of questions, but again, as a validated question saying, do you think you are at risk of becoming homelessness? And lastly, I have, you may be familiar with Prepare, which is a screen created by the National Association of Community Health Centers. It asks several questions to elicit information on housing insecurity. And all of these screens have advantages and disadvantages in terms of how likely they may be to accurately identify families, how long they take, and whether they fit into your workflow, but you have multiple possibilities to choose from. So what about the communication barriers for families who are housing insecure? So for families in your practice that have been identified as having insecurity, there are many barriers to maintaining appropriate communication and follow-up. And in fact, once you begin screening, you may uncover the reasons that some families have been non-adherent in the past. So typical barriers to effective follow-up that we all need to consider is the fear that you may be calling for medical reasons, but they may not wish to be found due to concerns about DCFS, immigration, other things like that. They may be moving around, which lead to interruptions in communication and access. Again, Dr. Moore mentioned the issue of phone access. And then there are often competing needs that the family is trying to address. So they may need to be going to a meeting for public aid or housing while you want them in your medical home. Shelters frequently have restrictions about exit and entry, leaving children in a center, which might make it functionally difficult for them to adhere to plans. And then frequently, these might be people who have had very little experience with a medical home that supports and prioritizes continuity of care. They might be accustomed to using emergency departments as their point of care, and therefore the entire concept may be a bit foreign to them. What are some of the actions that can be taken to address these challenges? And these are things that have been already found to have some success. So definitely, as we should do for all people, ask at every single visit. Contacts can change. That extra phone number or a secondary contact. Who is the person who always knows where you are or you can reach out to when in trouble? And this could be a variety of different people. Texting or emailing may actually be the best option for people. Libraries might have a public use computer, but I do want to bring up the consideration of only texting non-HIPAA information, since there could be HIPAA concerns in this format. Many systems do have patient portals, although low-income groups seem to be less likely to use them. And finally, mail is another possibility. So you can ask, where's a place that you can always receive mail? So what about follow-up? And how do we best do this? So when we're thinking about follow-up, considerations to help overcome barriers to adherence, including checking on transportation barriers, trying to be as flexible as possible with appointment times, as Dr. Moore mentioned, realizing they may not have the freedom to come at certain hours. One effort that can help is that one actually goes to meet them where they're at. So depending on your situation, and if you're in an FQHC, one could actually set up shop in the shelters where people are staying. Which of these modifications your particular practice will be able to institute will depend on your population, your staff, and your resources. So in summary, it's important to help families by screening for housing insecurity in culturally sensitive and unbiased ways in order to actually get them to disclose, and then offer interventions. Using specific screens which allow one to assess for different levels of housing insecurity, not just homelessness, and then thinking about how to communicate and follow up with patients to enhance, with enhanced efforts to make sure they can be reached and that they're able to access services. When we think about implementing this in practice, creating a process for assessing and identifying families is important, promoting that flexibility in scheduling as a priority for children and families in this situation, and then exploring all possible avenues for communication with families. So next, we're going to move on to some of the clinical guidelines that are really important for this population, and I'm actually going to present this as well. So these are clinical guidelines. We're going to cover, for our learning objectives, developing an understanding of clinical topics to be considered due to the impact of housing insecurity, and then develop skills in specific guidelines to best practice for delivery of care to meet the challenges that are created by those impacts. So we're going to talk about, as I said, the impact in the different realms and best practices for the encounters. So what are the clinical impacts of housing insecurity in the physiologic health, brain health, and social health realms? In the physiologic realm, these families that are challenged by housing insecurity have many reasons to be at risk of either under or inappropriate nutrition and suffer from both malnutrition, stunting, and obesity. Because they may skip meals, worry about the availability of food, and frequently consume foods with low nutritional quality but high fat content that makes them feel full. They're also at risk for multiple infectious diseases listed here, including tuberculosis, as well as infestations due to living in group settings where they have increased exposure and may have poor nutritional status. Dental caries, one of the most prevalent public health issues facing children, is also a more frequent health issue in this group. And when we think about children with chronic disease, for instance, using asthma as an example, both the prevalence and severity of that are markedly increased in homeless children over others, as well as are needing to think about accidents, since these children suffer from higher rates of accidents and injuries than lower income children with homes. What about the effects on brain or mental health. And due to both the effects of housing insecurity on the parents as well as the direct effects on the children, there are well-documented challenges in the area of brain health. There are both emotional distress, developmental delays, and decreased academic achievement, which are all more common. And even in preschool children, there's increased prevalence of developmental delay. As Dr. Moore mentioned, this is very traumatic, and trauma is known to cause developmental delay. Homeless children score lower on math and reading achievement tests than low-income students living in homes. And the mechanisms through which this operate are multifactorial, including factors such as increased risk of abuse, exposure to violence, and psychological trauma. And then what about in terms of the social realm? Because social disruption also leads to many challenges. And these children who experience frequent moves, that it interrupts their education and it impacts their school performance. And this is actually often exacerbated by the fact that from one study, 64% of the surveyed cities reported that shelters turn away families experiencing homelessness because of lack of available beds. So that while the families overall are more likely to be sheltered, they often are moving around and may even be separated depending on the age of the child. As well, frequent changes in location can lead to disruptions in benefits and transportation barriers to the clinics. They may no longer be housed in the same area. And there are increased rates of mental conditions and other health impairments that place families at risk of housing insecurity, and those that can also then affect the rest of the child's environment and the family's ability to cope. So domestic violence is reported at higher rate and may actually be the trigger for them becoming homeless. Whoops. Somehow this is not advancing. I'm not sure why. Sorry. So best practices for clinical encounters to address these issues. What about the history? So obviously, for all, we need to have a general comprehensive medical history, but we specifically need to think about things like eating behaviors and patterns, food security, and the barriers to health and diet. Sleep, you can imagine, becomes important because often in the shelters there may not be as safe a place to sleep as we would wish. Furthermore, the dental hygiene and prior history of appointments is important because frequently it's difficult for them to access care, which is difficult for the general population, but even more difficult for them. It's really important to address safety in housing and safeguarding and supervision. So due to the nature of shelters or other temporary spaces, they may end up having a lack of control over the environment, as well as moving to a place that has not been safeguarded. We mentioned the increased risk of infection, so it's important to specifically inquire about symptoms. And then due to unknown barriers to adherence, checking on chronic conditions and assessing and understanding obstacles to adherence with the management plan is really crucial. Developmental assessment is a key part to health maintenance for all children, but realizing these young children are at greater risk, it's really important to do that observation in the exam room and use formal tools such as the ages and stages questionnaire, which I think most people are familiar with. For children 2 and over, doing a social emotional assessment, again, either with ages and stages or with the PEDS, can be useful. Other parts of the history that need to be elicited in order to support families and try to prevent developmental delay would include daycare or school history and those interruptions, as well as that family history that can interfere with having a stimulating home environment. And what about the social history? Because social factors are so important for health outcomes, and we already know because they have housing insecurity that there are social issues, taking a detailed social history for these families includes such things as the family structure and supports, domestic violence, as well as parental drug and substance use challenges. Prior housing, interruptions in care, employment is important, transportation and communication issues, and taking that history of possible interrupted benefits. Consider if you feel that you are able to have a good response, if you have trauma-informed care, asking about adverse childhood experiences. Because it's only if we have this knowledge that we're going to be able to provide resources to mitigate some of the negative effects. So what about the clinical exam? It's really important to document and address, as we do for all people and children, but the weight for length when they're under 2 years and for the BMI when they're over 2 years, as well as the head circumference, since that's an important part of development. Blood pressure for those greater than 3 years or at a younger age if there are risk factors. Again, that focused observation on behavior and development. Doing a dental exam and application of fluoride varnish if you have that ability in your clinical session. This is one of the evidence-based practices that will help decrease dental caries. Also, a careful evaluation for infectious disease or infestation and a careful dermatologic exam. What things are important for screening? And again, a lot of these are things we do in general health maintenance, but these children are particularly at risk for these things. So checking a CBC or hemoglobin or a ferritin for anemia or iron deficiency, lead, tuberculosis screening. While we don't do that in everybody, these kids are definitely at risk. So if they're greater than 2 years and able to obtain enough blood for quantiferin gold, that would be preferred. But if they're under 2 years, definitely a PPD. Coming back for a reading can be an issue, but if you can find a certified nurse, let's say in a shelter or other place that could read it, that might be easier for these families. Determine which developmental, social, emotional screens you wish to use. And a note about vaccine records. Because of their interruptions in care, it's really important to try and get at these. iCare, which is a state registry, is a very useful tool in order to try and check on their full immunization registry. And then thinking about screens for specific conditions, such as using the asthma control test for asthma. And it's really important to consider constraints to effective management because, as Dr. Moore was talking about, their situations might necessitate that we alter our the way we are going to manage their conditions. So we need to consider what is their access to refrigeration and storage? What is their access to even electrical supply? Let's say they have an albuterol nebulizer. Even such things as fundamental needs and facilities such as bathrooms and kitchens, and also what is their privacy going to be, and what is the possible change in their living situation that we might need to take into account so that we're going to be able to follow up with them when we need to follow up with them. The privacy thing I do want to say is particularly an issue in shelters which have dorm style living situations. So some of the things that we need to think about are supporting resilience. And a lot of places have Reach Out and Read, particularly for these people, part of trauma-informed care is supporting families with the 7 C's of resilience, which I put down here, and mindfulness and meditating. And some of the resources we can give are actually for the parents who can then help their children. There are lots of parenting programs which are available that will help the parents because of all the stresses that they've gone through. And then the issue of supporting developmental and behavioral problems. It's very important to connect these people to early intervention. For particularly this group, the thing I want to point out is 0 to 3 is early intervention, and at older ages, obviously, they can take advantage of the school early intervention programs. But in terms of the actual evaluation, while many people think that early intervention does in-home evaluation, these child find centers, which are for school-age children, they're actually not just for school-age children. They actually can identify children and do evaluations all the way down to 0, and they may actually work better for this group. I also want to just lastly point out that we do have certain issues during COVID-19. There's been a lot of interruption in early intervention and school evaluations, and I've got a website here to make people realize that there are state-by-state allowances with changes for occupational therapy and other things. So I just wanted to point that out here, and that's basically what this is there. Further, there are, again, as I keep mentioning, the medical home may not be the only place. So there can be concrete community resources that we need to all be aware of in our medical home so that we can refer out. So if they're in a shelter, they may be supplied there, but things such as Medicaid, benefits assistance, transportation, and legal, as well as daycare and school assistance. So there's a program for CPS students in temporary living situation programs. So the model of care delivery that is recommended by the American Academy of Pediatrics, it includes optimizing acute care visits to best resolve patient concerns and provide care when possible, identifying the underlying causes of homelessness and facilitate connection to those appropriate resources, which again may be in the community, and then partnering with families to develop care plans that are actually feasible for them, acknowledging the barriers that they may have. I lastly just want to mention an administrative thing. There's actually a code for homelessness that I would encourage you putting into any billing that you do. And then for the electronic health record or medical record, one of the ways to designate housing insecurity or homeless is to put no fixed address. And you can also flag frequent users to then address when they come in whether they have housing insecurity. So in summary, housing insecurity places families at increased risk for poor outcomes. They may need to be screened for specific issues associated with housing insecurity in physiologic, brain health, and social realms, and the management of their care needs to account for the challenges and frequently requires community partnership. When we think about implementing practice considerations for this group, creating a template to support the clinical encounter can be helpful, adjusting management to incorporate the challenges, compiling lists of resources in your area by topic to distribute to patients, and then helping Medicaid enrollment to increase access to care. And with this, I'm going to pass on to the next presentation, and Jonna Lowe will now talk about referral options and tools.
Thank you. So by increasing our knowledge of the housing systems, we hope that we can make referrals for your patients and join ICAP and a housing advocate in their housing advocate efforts. Ooh. Oops, sorry, wrong way. In this section, we will cover a high-level overview of the housing system, various housing interventions, referral options, and then do a case study. We will discuss now a summary of the high level of the housing and crisis systems in Chicago. Communities have crisis systems that include shelter, domestic violence and human trafficking resources, and homeless prevention resources. We will talk about how to make referrals to crisis systems later in this section. The Chicago's coordinated entry tries to get the most vulnerable individuals into limited housing resources that our community has available. Individuals and households experiencing homelessness need to have a housing assessment completed to get connected to the appropriate housing resource. This slide shows the various housing interventions that our community has to offer. As I mentioned, coordinated entry tries to get those most vulnerable individuals and households into the limited number of resources. It is new in that their patient, it is new. The system is relatively new to the city of Chicago. And that is important to sort of communicate and understand that although the system exists, it does not mean that the system can make the most impactful outcome immediately for those patients and families that are in need. A coordinated entry process is not a quick one. The first step is engagement. Individuals or households may often engage at emergency entities like shelters or over the phone, especially now during the COVID-19 pandemic, and connect over the phone, call looking for support. Sometimes people are connected to alternate resources outside of our system if appropriate, like connecting them to stable supports like diversion or one-time financial supports. The second step is where households complete the housing assessment. Households are next prioritized in the system based on their assessment results. After that, households that have the highest priority get matched to the appropriate intervention based on need and availability. Households are then also matched with support staff to help them navigate the process and supports needed in the meantime, like getting an ID or proof of income. We often call these housing navigators in our sector. Finally, families and individuals are housed and provided supports to keep them stably housed long term. Usually this is through social work or case management supports. This section reviews different interventions that may be available to families depending on eligibility. So housing is not an entitlement program. Just because someone is eligible doesn't mean they will be able to access it. And that is really due to the fact that housing is significantly greater in the need than it is in the supply, particularly in Chicago. The goal of prevention is to keep households out of the homeless system, where households where they may need short-term resources or immediate problem solving can supplement through their current and existing incomes or other resources. And then rapid rehousing is usually offered when the supports needed can be or should be more than one time, but are not necessarily long-term or permanent. Subsidized affordable housing is when a stipend of payment supports the affordability for households. The goal is that households don't pay more than 30% of their income for rent. These resources aren't usually just waiting for utilization. We definitely see long wait lists for subsidized and affordable housing entities. The need is usually, as I mentioned before, higher than the demand. And then we have some statistics here that show what those realities are for households in our state. Supportive housing is affordable housing paired with supportive services to assist individuals and families in achieving goals, maintaining stability long-term. Households with someone in their household that has a disability, including the children, and have low or no income are usually the baseline criteria for supportive housing. This intervention is ideal for families that need additional supportive services long term. In this section, we will discuss how to refer, folks into these various housing interventions. Healthcare providers who do and do not have care coordination or referral support can focus on sharing text to connect flyer. We'll get to that slide soon. By texting the number on the flyer, the family can get connected to the correct entry point for support. Chicago's 311 is also a way to get connected to supports like prevention, diversion, and access to the coordinated entry system. So this is the text to connect flyer. We just did a screenshot. We definitely recommend that physicians post this at their office or hand them out if available. And this handout can be made available electronically. In order to be utilized as a supportive entity, it will require more attention, compassion, and time. I know Dr. Moore covered a lot of that earlier, but we just want to sort of reiterate that there's a need to push past the assumptions that we take for granted as folks who are living sort of stably housed in the supports that are offered. So it might include more staff time, more one-on-one support for the families that are experiencing housing insecurities, and then some of those best practices that were discussed earlier. So this is a referral tool, and we definitely want to mention Stephanie, who created this wonderful resource. But this referral tool is a guide to provide for folks to understand really how to access what interventions is best in a particular situation. So starting from the left is where you start, and then you sort of work your way toward the right, like sort of the response trees. I think that's what they're called. I just want to iterate the point in the beginning that the questions asked that are in the blue and green boxes are really highlighting particular demographics, because a lot of times we see funding resources and entities that can be population specific. So for example, the question about domestic violence and being a veteran and being a refugee is not that those questions are more important about does a family current have a safe or stable place or stable housing. It's just that those particular populations have access to their own immediate shelter entities. You know, this is available. This handout is also available and can be provided to sort of support. And we'll go over a case study later to discuss sort of how to utilize this. One other thing that I just want to point out too, there was some conversations around whether or not in the red box, accessing 311 to receive transportation if someone is experiencing street homelessness in the moment. And so at one point in time, by way of the pandemic, the hospitals were no longer allowing folks to really utilize sort of them as a place. But now Catholic Charities is still doing the transport. And we're just asking folks if they are at a hospital or at an ER to just sort of walk outside, maybe go a block away if they feel safe, and they can still receive that support as opposed to standing or being inside the ER or the hospital itself. Getting connected to shelters in the city and suburbs are through different systems. So Chicago, we have a continuum of care that sort of focuses on the homeless and emergency shelter system and housing systems that are offered through those, and so does the suburbs. And it doesn't necessarily matter. It doesn't actually matter which suburb, but just suburbs within Cook County. So for the suburbs, use the website to find a shelter that works best for the family's location, and that is best on, you know, any side of town or any suburb, really. Oh, I'm sorry, I didn't go to the next slide. Ooh, I think I'm going the wrong way. Yes. So yes, this is the website if you're trying to access the shelter system for suburban Cook County. And then if you are in the city, Shield of Hope is one of the bigger shelters. And then you can call 311, or if the city, the Department of Family Support Services has been utilizing the 10 South Kedzie location as shelters as well, particularly for families. So these are the resources for that. Make sure I'm going the right way. Okay. For families impacted by domestic violence or human trafficking, ensure that they are connected to the appropriate hotline. And that also is true for refugee families as well. So as I mentioned earlier, there's particular funding available for these populations. And when it comes to issues of matters of partner violence or domestic violence, the safety entity is a little higher than it would be, or those safety measures, excuse me, are a little higher than they would be in a sort of general population shelter. The Veterans Affairs, or VA as most folks call them, has a variety of resources available to veteran and veteran families. And so if you're working with a veteran family, providing them access to these resources may be the first entity and best support for them to utilize. As discussed previously, there are short-term resources meant to help families stay out of the homeless system. There are different ways to connect to diversion services between the city and county, so make sure to ask the family where they live. So those are the numbers provided for that resource. And then for Chicago homeless families that need to be connected to supportive housing, a healthcare provider or staff can call the call center directly. They must be with the patient. Again, this is not for everyone who needs immediate shelter. And so if you look at the eligibility listed, being in a shelter, being either street, what we call experiencing street homelessness, or living in a place not meant for human habitation, including, you know, those abandoned buildings. Oftentimes people utilize our public transit system and park system to take sort of space to refuge if they're experiencing homelessness. And we also, in our sector, look at people that are institutionalized as not being stably housed, because these are not permanent places to live. And then, of course, those that are fleeing partner or domestic violence and then human trafficking. I keep going the wrong way, I apologize. And then the same is true, except for the information and the access points for the Cook County. So Cook County has its own coordinated entry system, and this is how you can refer folks that are living in the suburbs. Have the same criteria as well. Families might also need to be connected to affordable housing. So as we talked earlier, everyone doesn't have the same sort of housing insecurity, and people might need long-term supports. The hard reality is that with most of these affordable housing entities, there are long wait lists, and that the wait lists themselves are not necessarily open at all times. But you see here, we have information about the Chicago Housing Authority. Cook County also has its own housing authority called Housing Authority of Cook County HAC. The Chicago Department of Family Support Services, or the Department of Family and Development of Affordable Rental Housing Resources, they have a website. And then there's also an entity called the State Referral Network that works with people who have disabilities and to have low income. And so you can access all of those things there. Sure. Oh, went too fast that time. And of course, we want to highlight the Head Start and Early Head Start programs. You can see the eligibility, and I'm sure none of this is new information to you all, but the importance it offers for families experiencing homelessness, as they are a priority within the Head Start and Early Head Start programs. So we can send out the links to those frequently asked questions, and then also how families can connect to that program itself. So within the school system, which is really important to talk about, there's assistance to students in pre-kindergarten through 12th grade and their families. The goals of the STLS program is to protect the educational rights of students in temporary living situations and to provide services to students and their families. So if you know of any child or youth that is in a considered a student in temporary living situation, including doubled up, including experiencing literal or street homelessness, and you can call that, the number is 773-553-2242, or you can access them through that link that is provided on the slide. And so some of the things I think is important to highlight within this sort of rights, which was presented by the McKinney-Vento homeless assistance I mentioned earlier, is that immediate school enrollment. So all schools must immediately enroll students in temporary living situations, even if the student lacks health, immunization, or school records, proof of guardianship, proof of residency, or any other documentation normally required for school enrollment. Students in temporary living situations can enroll without an adult present. The student in a temporary living situation is entitled to enroll in either his or her school of origin or any school that that student is sort of living in their temporary situation. And parents and students have the right to make any of the above enrollment choices, and that no board employee should discourage a student from attending his or her school of origin. Oftentimes, we see sometimes staff trying to provide the better decision for the family as opposed to letting the family advocate for what they want. But that, is a really important thing to sort of respect the choice. And that they must do, the board staff should do his or her utmost to support the student in his or her enrollment in that process. Other resources available include transportation. So the family or the caregivers chooses to continue the child's education in their school of origin, the board will provide transportation to and from the school of origin and all school-related activities as long as the child or youth is in a temporary living situation, or if the child becomes permanently housed until the end of that academic year. Students who temporarily reside outside of Chicago due to experiencing homelessness and attend their CPS or Chicago Public School of Origin receive transportation assistance, as do students experiencing homelessness who live in the city itself. School fees are also waived for students experiencing homelessness or involved in a temporary living situation. There's also services related to tutoring, providing uniforms, free school supplies, free school meals, and low or free medical referrals. In our vulnerable times of the pandemic, especially, having a phone has become much more paramount because we can't necessarily go to places in person or have incredibly long waits due to that social distancing. So we just wanted to make sure that we're including information about accessing the free cell phone program, which is a federal funded program. So you see the link on the bottom that provides that information for accessing sites here in our state. For the most part, I think the right approach is to have patients utilize a coordinated advice and referral program for legal services. This is provided throughout Cook County. They do provide those sort of consulting information over the phone for free, or if you want to sort of set up an appointment online, I think there is a $25 fee to do that. But they provide legal advice where appropriate for people to represent themselves. So this isn't necessarily about receiving a lawyer, but they're definitely, you know, because it's a free entity, we often see that the waiting for this hotline, which the number is located on the slide, is pretty long. And then it is important for parents of children with disabilities that they may qualify for disability income. And so we just wanted to provide the sites in the guideline book or the guidebook. Criteria for children is separate from adult criteria. So some of the experiences that we've heard about accessing Social Security for adults, it is a different criteria for youth and children. Families will likely need support and advocacy in this process. And so because we have that very detailed resource tool, we wanted to do a case study. So I'll give folks maybe about 30 seconds to read over it. And we can figure out, as Dr. Hastings or the Dr. Hastings on the phone, how, or on the webinar, how we would be able to support Ms. Johnson. So I'll wait about maybe 15 more seconds and then we'll hopefully provide some insight and have a small discussion about this. So understanding this referral tool that can be utilized for physicians, what do we think we could do for Ms. Johnson as Dr. Hastings? And what resources would we be able to share with the family? So we have a wonderful chat option. People can chime in there. Folks can also take themselves off mute if they want to discuss. Wait maybe another 5 or 10 seconds for folks to chime in. Don't be shy. Well, if I were Dr. Hastings, I think the first thing to do would be to provide sort of the safe space, as Dr. Moore mentioned earlier in the presentation, and sort of let them know you're happy that they were able to share this information with you, and that you want to be an entity of support. Oftentimes in our sector, we call case managers agents of change because people aren't cases to be managed. And so being an agent of change and providing sort of advocacy supports to people that are experiencing homelessness or having and experiencing housing instability, I think creates that cultural sensitivity that we discussed earlier. I think the second thing to do would be sort of to assess around issues of safety. So is Mrs. Johnson safe in the moment? When she leaves the office, will she be, you know, in danger? And just really figuring out what those situations look like. And then referring back to this wonderful referral tool, that green box highlighted at the top. So you would sort of access for safety, if that involves calling the police, DCFS, the Department of Child and Family Safety, and then if things are well in that space, you can move forward to actually calling the domestic violence hotline. Oh, I don't know, something happened with the screen. Let's see if I can get us back to that slide. Oh, I think we may have moved forward a little too fast. So just going back to calling that DV hotline, and then provide a space or opportunity for the person to, or for the patient to call from the office if necessary, and then discuss any sort of follow-up supports. And now I am going to, this is just a slide that sort of reviews or revisits the resources mentioned, which definitely is a lot of information. And as amazing physicians, you all have the ability to be those agents of change and real supportive and compassionate resources to any patients and families experiencing housing instabilities. I think on behalf of our sector, the homeless sector, we want to thank you all for being interested in figuring out and finding out ways to be supportive to this population. While this is a lot of information to process, access to information and some introductory knowledge can make a tremendous difference in the lives of children and their families. And so before turning back over to Tim, we of course want to thank those who sponsored the collaboration and understood the importance and the intersectionality of these matters. And so we see those sponsors. And I will turn it back over to Tim.
Thank you so much, Jana, and thank you also Dr. Moore and Dr. Belden. You all did an incredible job. As Jana said, a lot of information. And so I'm sure there's probably some questions here. So what I'm gonna do, just because we only have a few minutes left, and obviously folks can stay on a little bit longer if they like, and we're still here to discuss, but just because I know we're close to the end of our scheduled time, I just wanted to remind everyone again that we're gonna have a short evaluation when you log off the webinar. It should pop up automatically, just to give some feedback on how everything went. And then also, I'm going to be sending out a short, should take about 2 or 3 minutes, just quick post test to kind of gauge knowledge gain and see how we're doing. But yeah, so moving on to questions. I think a couple people posted questions in the question and answer box function here on GoToWebinar. So I'm going to read through those, but also right now, if anyone has any questions, again, everyone is now in control of whether they're muted or not, so you can go ahead and just speak up if you want, or you can raise your hand. But I'm going to go ahead and open up the question box now and see if there's anything. So anyone feel free to speak up while doing so. Oh, it looks like we actually had someone answer. Kim Parker actually, it looks like, answered the case study correctly, referring to DV hotline, so good job there. But yeah, if anyone has any questions, feel free to shoot a question to the question and answer box, or raise your hand, or you can take yourself off mute and just go ahead and ask. So I'll open the floor to you all. I saw one hand raised. I don't know if it was from earlier or not, but Tanya Hossein, I don't know if you still have a question or not. You could either speak up or send the question box if you still do. All right, so I think I just want to make sure again if anyone has any questions before I go ahead and close this out, because I don't see anything yet. Let's wait a couple more seconds before we go ahead and, oh, hold on. I have a question here from Ms. Parker again, or Dr. Parker, excuse me. How long do you recommend following a patient or family once shelter placement is secured? That's a good question. Does any one of our panelists have a response to that?
This is Dr. Belden, Barb Belden. I'm not sure exactly in which way you are meaning following them. You know, from my perspective, when we think of the supports we want, they're both going to be the social supports to make sure they're getting what they need, as well as the medical supports. And one of my, I'm not sure, favorite but most common things, it sort of depends, but I think even once they've found a placement, the from my perspective as a physician, they're at risk. And then I would be continuing to follow them. And it would somewhat depending on what the situation is, but this would be a family that I would be probably following at least every 2 to 3 months. Because remember, these are mainly young children that we're talking about.
Thank you, Dr. Belden, for your answer. Does anyone else have any questions? And again, you can ask by any means you like. You feel free to speak if you want.
And actually, to expound on that answer, it wouldn't always be the physician themselves that would be following. You know, again, this is a team, so it depends on who you have on your staff, et cetera. I think, you know, what I've found is that many of these families have a very difficult time, as we were talking about, accessing services. And so generally, like if I'm referring them to early intervention or whatever it may be, I'm not making the assumption at all that they are actually, that the circle is completed. And so somebody in my group or through a connection with a community agency, I would want to be following up to make sure that that loop had been actually closed.
That's great. Thank you, Dr. Belden, for expanding on that for everyone. So I just want to ask one more time if anyone has any questions. I don't see anything else yet, but please feel free to either ask a question in the questions pane or to just unmute yourself and you can go ahead and ask. Raise your hand if you like, whatever works. I'll just wait a couple more seconds just in case there's any last questions. All right, so I don't see any additional questions. So I think with that, we can go ahead and close out the webinar. If you all have any more questions, please feel free. You can email me at ICAP or Mary Elsner, my coordinator. You can reach me at therring, THERRING, at illinoisaap.com. And thank you all so much for getting on this webinar today. A lot of work has been put in from all of our contributors on both sectors because we recognize how necessary this is to connect, especially in this time, and you all are going to be on the front lines of that. So thank you for your interest. Thank you for your attentiveness, your participation. And as I mentioned before, we're going to be sending out this webinar as it's been recorded to you and also posting on our website. And because we want to keep doing this great work and improving and making sure that we get everything across the right way and the best way, please take a couple moments to fill out the short evaluation. It's going to pop up after this webinar closes, and also to fill out the short post-test that I'll send as well. So thank you all again, and I think we can go ahead and close out. So thank you all very much. We appreciate it. Have a great afternoon, and you'll hear from us shortly. Thanks.